It's my pleasure to welcome Dr. Mingfeng from China.
Thank you, Professor Postic, for introducing me. Good afternoon, everyone. First, I would like to thank Professor EGIR&MASLD to give me the chance to attend the meeting and learn from the experts in the research area of NAFLD. And it is also a great honor for me to share our recent work on the relationship between altered redox state and the development of NASH in Chinese adults. As we all know, NAFLD has become a global health problem that affects about 25% of world's population. And the NAFLD is actually a spectrum of liver lesions ranging from simple steatosis to NASH, liver fibrosis, and hepatocarcinoma. And most of previous studies indicated that the stage of NASH is still reversible after effective treatment. But once developed into the stage of liver fibrosis, then the liver pathological change is likely irreversible. And also previous studies indicated that the risk of hepatocarcinoma and liver-specific mortality was more than 10 times higher in patients with NASH compared with the patients with simple liver steatosis. So it is crucial to identify the patients with NASH clinically, and the patients with NASH should be targeted for further treatment. And in the recent decade, actually great progress have been achieved in non-invasive diagnosis of NAFLD. For evaluation of liver steatosis, we have imaging technologies such as MRS and PDFF, which can accurately quantify the degree of liver steatosis. And for the evaluation of liver fibrosis, we also have imaging technologies such as the MRE FibroScan, which can accurately measure the liver stiffness and also give an accurate diagnosis of liver fibrosis. But for the non-invasive diagnosis of NASH, it is still a big challenge in our clinical practice. And most of previous attempts on non-invasive prediction of NASH were limited due to the moderate accuracy, limited validation, and also we still lack a reliable imaging technology that can accurately identify the patients with NASH. So in the practice guidelines from ESO and American Association for Study of Liver Disease, they state that none of the non-invasive tests are validated for diagnosis of NASH, and the NASH have to be diagnosed by liver biopsy. And in patients with NAFLD, actually the metabolic syndrome could predict the presence of steatohepatitis. So its presence can be used to target patients for liver biopsy. So at present, we still have a long way in the non-diagnosis of NASH. But in the last year, several large-scale global validation studies actually have achieved some breakthrough in the area of non-invasive diagnosis of NASH. Actually, the two studies established two novel NASH prediction score, namely NIS4 and the FibroScan AST score. They predict NASH based on blood parameters and the FibroScan technology. Both of the two scores can moderately predict the presence of NASH in a global population with high repeatability and an AULC of about 0.8. And it will be ideal if we can further improve the accuracy of the global validated NASH prediction score in our clinical practice. And according to previous attempts on non-invasive diagnosis of NASH using metabolomic parameters. We believe that the use of metabolomic will further improve the diagnostic performance of a NASH prediction score in clinical. So our recent work aimed to establish a new NASH prediction score based on common clinical metabolic and metabolomic parameters to establish a new NASH prediction score. And we also plan to validate the metabolomic-based NASH prediction score in populations from different ethnicities. To do that, we enrolled 311 patients who underwent liver biopsy from Zhongshan Hospital, Fudan University, Shanghai, China, between 2012 to 2022. The cohort consists of 54 normal, 58 NAFLD, 77 early NASH, and 122 fibrotic NASH patients. We collected the season samples of all participants, and these samples underwent metabolomic examination. After that, we put the 77 clinical variables, 130 plus 254 derived lipoprotein variables, and 49 plus 21 derived small molecule variables into the analysis. And we further established the NASH prediction score based on machine learning based selection method. Then we further validate the NASH prediction score in a finished cohort. Our metabolomic platform can directly measure 130 lipoprotein subfraction parameters and 41 small molecule metabolites, including amino acids, ketone bodies, glucose, carboxylic acids, and so on. We can also measure two acute phase marker for inflammation, namely NAG1, NAG2, and also 6 parameters for fatty acids. So after statistical analysis, we can find that a total of 160 lipoprotein parameters were associated with the progression of NAFLD in our Chinese cohort, including 76 VLDL parameters, 30 LDL parameters, 51 HDL parameters, and 51 other lipoprotein parameters. And among all the altered lipoprotein parameters, the VLDL1 components have the most increase, including VLDL1 free cholesterol and the VLDL1 total cholesterol. And the subfractions of HDL, like HDL4 free cholesterol, HDL3 cholesterol, had the most decrease in the patients with NAFLD and the NASH compared with the patients without fatty liver. And if we further look into the relationship between the season small molecule metabolites and the NAFLD progression, we can find that a total of 19 small molecule metabolites were significantly changed with the progression of NAFLD. And the season ketone body levels had the most actually have the biggest change with the progression of NAFLD. As we can see here, the season beta hydroxybutyrate level was significantly increased in the patients with NAFLD and the NASH. But it's interestingly that we found that with the progress of NAFLD, another type of season ketone body called acetoacetate was significantly decreased with the progression of NAFLD. This phenomenon actually is very interesting to us, but at that time, we cannot find a good explanation for this finding. So we just continue with our NASH prediction model. So we entered all the parameters into 2 different machine learning models and selected the candidate parameters that had the highest correlation with the presence of NASH. Then we selected the optimal combination using the maximal AURLC. And then we further simplify this model and finally get the metabolomic-based NASH prediction model in Chinese. And this model was consisted of 6 parameters, including serum AST, BMI, tyrosine, beta-hydroxybutyrate to acetyl-acetate ratio, leucine to isoleucine ratio, and total VLDL phospholipid percentage. And in Chinese adults, actually this model have a good diagnosed performance with the AURLC of 0.87. And we further use this model in the Finnish cohort from Professor EGIR&MASLD lab. And we also find that the NASH prediction score have good diagnostic performance in the Finnish people with AURLC of about 0.84. But we still don't know why the change of beta-hydroxybutyrate and acetyl-acetate were opposite with the development of NASH in Chinese adults until we found this paper recently published in Professor EGIR&MASLD's lab. Then we realized that actually the ratio between beta-hydroxybutyrate and the acetyl-acetate reflect the individual redox state, which was correlated with the personal, the in vivo ROS production and also the mitochondrial function. So with the progression of NAFLD in Chinese adults, this ratio was significantly and continuously increased in NAFLD patients and NASH patients. And actually, this increasing trend was very consistent in the Chinese population, even if we divided the population into subgroups according to their sex, age, and the BMI level. We also investigated the quantitative relationship between the redox state and liver histological features. We found that the serum beta-hydroxybutyrate to acetyl-acetate level was positively associated with the liver steatosis, ballooning, lobular inflammation, and fibrosis grace. And it's also positively correlated with the BMI level, serum triglycerides, and fasting plasma glucose. But even if we adjust age, sex, and all the common metabolic parameters into the multivariant regression model, the serum beta-hydroxybutyrate to acetyl-acetate level was still significantly correlated with the increased risk of NASH in Chinese adults. So we can conclude that the altered redox state might play an important role in the development of NASH in Chinese adults. And also recent work by our group found that with the progression of of NASH, another protein called JAK2 is also significantly upregulated in hepatocytes. And the functional study shows that this protein could cause abnormal splicing of the mitochondrial functional mRNA. Thus, it will impair the mitochondrial function and cause the liver steatosis and promote NASH. But if we treated the hepatocytes with the JAK2 inhibit, it will recover the normal splicing of the mitochondrial functional mRNA. Thus, it will recover the mitochondrial function and improve NAFLD and the NASH. So the mitochondrial function might be a promising therapeutic target to treat NASH, which might deserve further investigation. So at last, I would like thank Professor Xin Gao from Zhongshan Hospital, Fudan University for her guidance, and thank Professor Hua Bian and all the other members from my group for their help in my research work. Also, I would like to thank Professor EGIR&MASLD and Sammy for their help to test the NASH prediction score. I would like to thank Professor Huiru Tang for the technical support in the metabolomic examination. Also, I would like to thank Professor Jingya Li for the cooperation in the JAK2 project. And thank you for your attention.
Thank you very much for your very nice presentation.
Thank you.
So we have a question from the Q&R from John Jones. Is asking about the potential relationship between the redox state and the fibrosis in the patient, whether fibrosis state could have affected also measurement or state of redox in your metabolomic studies. Can you comment on that?
Sorry, I didn't see the question. Is the question about how much of the altered redox state?
Yes, redox state might be due to poor perfusion of the liver due to fibrosis.
Yeah, I think it might be influencing effect, but as we can see that the accumulation of the redox state just started at the stage of early NASH. So I think it's not a main reason for the altered redox state.
Okay.
Yeah, maybe other metabolic procedures is a main reason.
Thank you. I had a question, but you showed it at the end of your talk, because I was wondering whether you had a difference between men and women in your cohort, but you showed that when you segregate also, you see the same differences between men and women, right? In terms of redox state. You showed that at the end of your talk.
Sorry, let me go back.
No, it's okay.
I think I didn't.
The gender issue you addressed.
I didn't. I think I didn't find a difference between male and female participants, but for the patient with metabolic disease and without metabolic disease, actually the redox state, the level are different. So for the obese person, actually the average level for the beta hydroxybutyrate to acetoacetate is higher than the patient.
Yeah, but you didn't see any difference in men and women.
Yeah.
So we have a question from Christopher from the panel.
Great, thank you, Catherine. Well done, Mingfeng. That was very nice. This brings me back to the question to Panu about differences in mitochondrial function between the patients who have different degrees of severity of NASH. And if you have NASH with fibrosis, you're very different from NASH without fibrosis. And it's perfectly conceivable. In fact, there's some evidence that with that fibrosis, you've got mitochondrial damage. And the conversion of acetoacetate to 3-hydroxybutyrate is a dehydrogenase in the mitochondria that's responsible for that conversion. So I just wonder whether the differences you've got in acetoacetate and 3-hydroxybutyrate are reflecting different degrees of mitochondrial damage.
Yeah, I think it's a very good question, but I think based on my data, it's very hard for me to answer your question. Yeah.
It would be nice if you
had. But I think if we just remove the, the last group and compare the patients with simple steatosis and the early NASH, actually these two groups have a significant difference. So I think the mitochondrial damage might be a reason, but
so it might be worthwhile stratifying your NASH group by severity of fibrosis.
Okay, yes, it's a good suggestion, and I think I will do it later to see if it. Yeah.
Thank you.
Yeah, that's good.
Thank you.
Panu?
Yeah, very nice work. I was wondering that because in my hands I was able to see the association between the beta hydroxy acetoacetate ratio and the genetic variants, but not too much with the insulin resistance. So did you have any data on the genetic variants in your data?
Yeah, we plan to do it. Actually, it's we are already doing it. So maybe I will let you know the result 1 month or 2 months later. I hope I can just repeat your results. Yeah, very nice work.
Sounds great. Thank you.
Thank you very much. I think it's time to close this first session.